The knee. It's more than just a hinge, it's the pivot point for power, stability, and control. Today, we're going beyond the textbook diagrams and going to try and use some real time diagnostic ultrasound. We'll watch the muscles that move the knee in action, deep to superficial, flexors to extensors, and everything in between. The knee is a hinge joint with a twist, literally. It moves primarily through flexion and extension, but with a subtle rotation when the knee is flexed. Muscles that act on the knee come in three key regions: anterior thigh, posterior thigh, and the lower leg. Let's start with the ones you probably know best, the quadriceps. The quadriceps femoris is a group of four muscles that share one crucial task, extending the knee. But each member of this team brings something unique to the table. The rectus femoris, originating from the anterior inferior iliac spine and inserting into the tibial tuberosity via the patellar tendon, is the only biarticular quadricep muscles. It flexes the hip and extends the knee. But when you're seated with the hip flexed and you try and lift your leg, active insufficiency kicks in, reducing the rectus femoris' ability to generate force. Vastus lateralis, originating on the greater trochanter and lateral linea aspera, inserts onto the tibial tuberosity via the patellar tendon. All the quads do. This muscle is key for lateral knee stabilization, especially during lateral movements like side-to-side lunges. The VMO, vastus medialis, originates on the medial lip of the linea aspera, inserts onto the tibial tuberosity via the patellar tendon. The VMO is critical for patellar tracking, especially when you extend the knee in the last 20 degrees or so. Then we have the vastus intermedius, originating on the anterior lateral shaft of the femur, inserting into the patellar tendon again, is the unsung hero of knee extension, working beneath the rectus femoris. It's a deep muscle, you don't see it a lot. The hamstrings run along the back of your thigh and flex the knee, but that's just the start. The biceps femoris originates from the ischial tuberosity, the long head that is, and linea aspera, with a short head, and insert onto the head of the fibula. This muscle's lateral attachment rotates the tibia externally when the knee is flexed. The semitendinosus originates on the ischial tuberosity, inserts on the pes anserinus of the medial tibia, and internally rotates the tibia during knee flexion. Semimembranosus originates on the ischial tuberosity, inserts into the posterior medial condyle of the tibia, and it works with the semimembranosus to stabilize the medial side of the knee. Hamstrings, being biarticular, struggle when the hip is extended and the knee is flexed. Active and passive insufficiency occurs as well, just like in the rec fin. The gracilis, the only biarticular adductor, originates from the ramus of the pubis and inserts to the pes anserinus. This biarticular muscle assists in knee flexion, but it loses efficiency if the hip is already flexed. While we think of the hip abductors as hip movers, they play a role in knee stability too. Gluteus medius and minimus. By controlling the hip position, they can limit valgus collapse of the knee, which is knee cave. The TFL inserts into the iliotibial band, which does stabilize the lateral knee. These next couple of muscles cross the knee from below, assisting with the knee flexion and rotational stability. We have the gastrocnemius, medial and lateral heads, origin on the medial and lateral femoral condyles, and they insert into the Achilles tendon. These biarticular muscles flex the knee but become passively insufficient when the ankle is dorsiflexed. Then we have the popliteus, originating on the lateral condyle of the femur, inserts onto the posterior surface of the tibia, and it's known as the key to the knee for initiating tibial internal rotation, which allows the knee to lock and unlock during flexion and extension. Then we have the plantaris, originating on the lateral supracondylar ridge of the femur and inserting onto the calcaneus via the Achilles tendon. It's kind of a shrimpy muscle which flexes the knee, but it plays a critical role in proprioceptive feedback from the ankle. The knee joint is structurally complex, relying on several tendons, ligaments, and supportive structures to provide stability, mobility, and force transmission. Key tendons of the knee include the patellar tendon, and it originates on the inferior pole of the patella, inserts onto the tibial tuberosity, and it transmits force from the quadriceps to the tibia, enabling knee extension. There's patellar tendinopathies such as jumper's knee, especially in jumping athletes like basketball athletes. The quadriceps tendon, originating on the convergence of the four quadriceps muscles, so just superior to the knee, inserts into the base of patella. It facilitates knee extension by transmitting force to the patella and subsequently to the tibia. It's continuous with the patellar tendon. It is relevant clinically because it can suffer from tendinopathy or ruptures during high-load activities. Hamstring tendons of the semitendinosus, semimembranosus, and bicep femoris originate on the ischial tuberosity, except for the biceps femoris short head, which is from the linea aspera, inserts onto the medial tibia, except for the biceps femoris, which inserts into the fibula. It enables knee flexion, hip extension, and rotational stability. Strains are quite common in sprinting athletes for these. The pes anserinus tendons, the gracilis sartorius and semitendinosus, insert into the medial proximal tibia. They provide medial knee stability during dynamic movement. Pes anserine bursitis can cause medial knee pain. The IT band originates from the TFL and gluteus maximus fascia, inserts onto Gerdy's tubercle on the lateral tibia, and it assists in lateral knee stabilization during movement. IT band syndrome is common in runners and cyclists. The popliteus tendon originates on the lateral femoral condyle and inserts onto the posterior surface of the tibia. It initiates knee flexion by unlocking the knee, which is tibia internal rotation. Popliteus tendinopathy may occur from rotational stress, such as a plantar twist. Then we have several key ligaments, which are crucial to stability of the knee joint. We have the ACL, anterior cruciate ligament, which prevents anterior tibial translation. Then the PCL, posterior cruciate ligament, prevents posterior tibial translation. The medial collateral ligament, MCL, resists valgus forces, or knee cave. Then the lateral collateral ligament, LCL, resists varus forces, or kicking your knee out, right? Some supporting structures to mention are the menisci, medial and lateral. They absorb shock and distribute load across the joint. Then we have the suprapatellar, infrapatellar, and prepatellar bursae, which reduce friction between the tissues. Then the knee joint capsule encapsulates the joints and contains synovial fluid for lubrication. I'll close this by saying the knee is more than just a hinge joint. It's dynamic and adaptable. The muscles don't just move it, they protect it. From the massive quadriceps driving extension down to the little small popliteus unlocking rotation, every muscle has a distinct role, and that's the end of the overview. I hope you found that helpful. If not, be sure to let me know in the comments. These are for your benefit. Peace.